Hey everybody. Today I want to talk about the pancreas and its role in regulating blood sugar as part of the endocrine system. But first let's just take a step back and remember the role of the pancreas in the digestive system. So we've talked about the pancreas before in the digestive system. Here's the pancreas. We're looking at an anterior view, which means that if somebody is standing in front of you and they're facing you, then you're looking at them, the front of them, and that's what we're seeing. Here's the head of the pancreas. This is in the upper right quadrant of the abdomen, and then it extends across the abdomen, and the tail extends into the upper left quadrant of the abdomen. Now, the digestive role, if you remember, the digestive role of the pancreas is to secrete pancreatic juice that contains all of the different types of digestive enzymes. Amylases that break down carbohydrates, lipases that break down fats, and proteases that break down proteins. And so these cells right here, these pancreatic cells, produce pancreatic juice. They secrete that into the pancreatic duct, and then it moves from the pancreatic duct into the first part of the small intestine, which is the duodenum. And there, that pancreatic juice starts digesting all of the major macronutrients, carbohydrates, proteins, and lipids. And that function, the digestive function of the pancreas, is considered an exocrine function. Exocrine means that we're secreting substances onto body surfaces or into body cavities that are exposed to the external environment. And this is considered exocrine, an exocrine secretion, because the duodenum is exposed to the external environment up at the mouth and down at the anus. And the duodenum is continuous with the pancreatic duct. And so these digestive secretions are considered exocrine. But the pancreas is also part of the endocrine system. And the role of the pancreas in the endocrine system is to regulate blood sugar. Now, we talked about exocrine secreting stuff into open body cavities, exposed passageways. Endocrine refers to secreting substances into closed fluid compartments. So the interstitial fluid in between the cells, or in this case, into the blood. When chemical messengers, when hormones are released into the blood, that's considered an endocrine function. And so the pancreas is going to regulate blood sugar by secreting the hormones insulin and glucagon into the blood. Here we're looking at some histology of the pancreas, and here's a drawing of what that histology would look like. And all of these cells right here that surround this duct represent the role of the pancreas in the digestive system. So it's these cells that are going to produce pancreatic juice secreted into this duct, and then that duct is going to eventually funnel into the pancreatic duct. The endocrine cells of the pancreas then are located within these structures called pancreatic islets or islets of Langerhans. And that's represented by these cells here. If we look at the actual histology, all of this area in here, this all represents cells that are going to produce pancreatic juice and serve a digestive role. And then if you look closely, and you can see this here, we have this cluster of lightly stained cells, and that represents an island of Langerhans. So those are the endocrine cells of the pancreas that are going to produce insulin and glucagon. So there's a couple different types. Actually, there's a few different types of cells within these islets of Langerhans. We're going to talk about two of them. One of those are alpha cells, and you can see these darker colored cells are alpha cells. And these alpha cells are going to release the hormone glucagon into the blood. And you can see that you have little capillaries that are in close proximity to these endocrine cells because, again, these cells are going to release these hormones into the blood. So alpha cells are going to release glucagon, and then you have beta cells, and these are all beta cells, and the beta cells are going to release insulin into the blood. And like I mentioned earlier, the stimulus for the release of both of these is going to be blood sugar levels, or what we refer to as glycemia. If blood sugar levels are high, then one of these hormones is going to be released to try to bring it back down. If blood sugar levels are low, the other hormone is going to be released to try to bring them back up. This figure that we're looking at here represents the regulation of blood sugar in the body, or what we call blood sugar homeostasis, regulating blood sugar to remain within a certain limit all throughout the day. And the first question I want to ask is, why do you think stable blood sugar levels are important? Why is it important to have sugar in the blood at all times during the day? Well, that sugar is going to be, that glucose is going to be used by the cells of the body. The cells are going to take that glucose up and they're going to convert that to ATP as part of cellular respiration. So if blood sugar levels are too low, that means that the cells aren't getting enough sugar. And if blood sugar levels are too high, that means perhaps they're getting too much sugar. And also too much sugar in the blood, as we'll find out with diabetes, can damage the blood vessels. So we want to keep it within these tight limits throughout the day. First of all, let's look at when blood sugar levels are elevated. Okay, they're higher than normal. And when blood sugar levels are higher than they should be, we call that hyperglycemia. Glycemia refers to blood sugar and hyper means above. So blood sugar levels are higher than they should be. Now, when would this occur? When would hyperglycemia occur? After a meal. After you've eaten a meal and nutrients start getting digested and sugar starts moving from the digestive tract into the blood. Okay, so you have blood sugar goes up because you've eaten a meal. That high blood sugar is going to be detected by the pancreas itself. And in response to those high blood sugar levels, the pancreas is going to release insulin in the blood. And it's the job of insulin to bring blood sugar levels back down to where they should be. How's it going to do that? Well, first of all, insulin is one of those hormones that acts on nearly every cell of the body. Nearly every cell of the body has receptors for insulin. And so insulin is going to basically bind to nearly all the cells in the body, and it's going to cause those cells to take glucose from the blood and bring those into the cells. So when you take glucose out of the blood and bring it into the cells, you're helping to lower blood sugar, while also allowing those cells to take it in glucose so they can, again, convert it to ATP. And insulin is also going to act on the liver, and it's going to tell the liver to take up glucose, except, the liver is going to use some of that glucose to generate ATP. But what it's also going to do is it's going to take that glucose and it's going to store it. And it stores it as glycogen. So what glycogen is, just a polymer that's made up of individual glucose units. So this whole thing is glycogen, and then each one of these little units is a glucose unit that's chemically bound to the glucose next to it by covalent bonds. And so that's a storage form of glucose. And so both of those taken together lower blood sugar, lower levels of glucose in the blood, and bring it down where they need to be. What about the opposite of that? When blood sugar levels are too low. And when blood sugar levels are too low, we call that hypoglycemia. Hypo meaning low. First of all, when would hypoglycemia occur? Well, hypoglycemia would occur if you haven't eaten for a while. Maybe overnight or just without a meal for an extended period of time. Okay, is when hypoglycemia would occur. So again, here we have blood sugar levels are low. And again, these blood sugar levels are going to be detected by the pancreas itself. And by the way, when an endocrine gland releases hormones in response to nutrient levels or levels of a chemical in the blood, we call that a humoral stimulus. So blood sugar is considered a humoral stimulus. Levels of blood sugar stimulate the pancreas to release hormones. But during hypoglycemia, when blood sugars are low, the pancreas is going to release the hormone glucagon from the alpha cells. And it's the job of glucagon to raise blood sugar back up to where it's going to be. How's it going to do that? Well, you can probably guess what it's going to do. It's going to act on the liver, and it's going to tell the liver to take that glycogen and to break the chemical bonds between these individual glucose units and then ship those glucose units out into the blood. So we're taking that store of glucose, as glycogen, and we're breaking it back up into individual glucose units and sending it into the blood, and that brings, again, blood sugar back to where it needs to be. Now let's take a close look of how insulin acts on a cell and allows that cell to take up glucose. So first of all, here's any cell of the body. Here's the plasma membrane. And here is a blood vessel, and this would be at the capillary level because that's where stuff can move in and out of the blood. And one thing I want to point out, here we have glucose in the blood. Glucose cannot move through the plasma membrane on its own. It's simply too large to do that. So it's unable to do that. So it needs help getting across the plasma membrane. And to do that, we have these transporters called GLUT4 transporters or glucose transporters, which are stored inside the cell, and they can move up to the plasma membrane and provide a passageway that allows glucose to move from the blood into the cell. So how does all of this happen? Because normally these glucose transporters are located inside the cell. They're stored inside the cell. They're not up at the plasma membrane. So what happens here is we have the hormone insulin. This is the three-dimensional structure of insulin. It's a protein hormone. Insulin is going to move from the capillaries, from the blood. It's going to diffuse out of the capillaries, and it's going to bind to its receptor on the plasma membrane of a cell. So insulin binds to its receptor on the plasma membrane of the cell, and that's going to activate the receptor and stimulate this incredibly complex pathway within the cell that we call a signal transduction pathway. Okay, this is just a series of chemical reactions within the cell that are going to cause the desired effect of that hormone to occur within the cell. So again, insulin diffuses out of the blood, binds to its receptor, that activates the receptor, which stimulates this signal transduction pathway, and it goes through all of these different PI3 kinase pathway, all these different pathways. But the end result here is that it causes these GLUT4 transporters to move from inside the cell up to the plasma membrane. And that gives this glucose a pathway to move from the blood inside the cell. So this allows insulin, the actions of insulin allow glucose to move from the blood inside the cell. And then again, once it's inside the cell, it's going to be used for cellular respiration and to be converted into ATP. I really like this picture here because it shows how the digestive system, the liver, and the pancreas all work together to regulate blood sugar. So here we have all of these we have the small intestines and the large intestines, and this shows these structures being drained by this venous system. And so nutrients from the small and large intestine enter into this venous system, and where do they go? Where do they go first? They go to the liver. And that occurs through what we call the hepatic portal vein. Maybe you've heard of that before. So here's the hepatic portal vein that ultimately takes nutrients from the digestive tract, and before they're sent out into the systemic circulation, they first go to the liver. And so the liver can do two things with that. Let's talk about glucose. So we have glucose that's taken up by the small intestines. Use this color. We have glucose that's taken up by the small intestines. It goes into the hepatic portal system. It goes into the liver, and the liver can take that glucose, and there's two options. What are those two options? Well, it can store it as glycogen, or it can ship it out into the blood, into the systemic circulation. What's it going to do? And when's it going to do that? Well, here's the pancreas, and the pancreas is also drained by this venous system. And so the pancreas is detecting blood sugar, and based on those blood sugar levels, let's say blood sugar levels are high, the pancreas is going to release insulin. Insulin goes into this hepatic portal system. It acts on the liver, and it tells the liver to take that glucose and store it as glycogen. Okay, so before this glucose even goes into the blood, the liver has the opportunity, the liver under the control of the pancreas has the opportunity to take that glucose and store it as glycogen, which would make sense because, again, if blood sugar is too high, then we don't want it going into the blood. And the opposite is true. If blood sugar levels are low, then the pancreas is going to release glucagon, and glucagon is going to go up into the blood, into the liver, and it's going to allow the liver to take that glucose and ship it into the blood, allow it go into the systemic circulation to help raise blood sugar. Okay, so we're going to move on into diabetes, but before we do that, I just want to take a moment and talk about pancreatic cancer, because pancreatic cancer is something that it's a relatively common cancer, and it can be pretty devastating. So there's two different types of pancreatic cancer. One is called pancreatic ductal adenocarcinoma, or more just what commonly we refer to as pancreatic cancer. And here we have a normal pancreas, and here are all the cells, the exocrine cells that line these ducts, and they're going to produce pancreatic juice and release it into the ducts. And what pancreatic cancer does is it affects these digestive-related, these exocrine cells. It affects these epithelial cells that are going to produce pancreatic juice. And you can see that it's just it's an abnormal situation there with this pancreatic ductal adenocarcinoma. The point being is that it's affecting these epithelial cells that line the pancreatic duct. Pancreatic cancer can be a pretty devastating diagnosis. The percentage of mortality is as high as 95%, And one of the reasons that's the case is because pancreatic cancer is often detected at a late stage. There's not a good way currently to measure pancreatic cancer in its earliest stages. And so there are treatment options. You can take part of the pancreas out that is being affected by the cancer. But probably the biggest single thing that is going to help with the survival of pancreatic cancer is early detection. And they're working on molecular methods that are going to help with that early detection of pancreatic cancer. The other type of pancreatic cancer these tumors are referred to as pancreatic neuroendocrine tumors. And unlike pancreatic cancer, these pancreatic neuroendocrine tumors are going to affect the neuroendocrine cells of the pancreas. So they're going to affect those cells in the islets of Langerhans. And this is a much less common form of pancreatic cancer. Maybe 1 to 3% of pancreatic tumors are this specific type, these neuroendocrine tumors. But one thing that can happen if you have one of these neuroendocrine tumors, if you have a proliferation of the beta cells, for instance, let's say the tumor represents a mass proliferation of the beta cells. Well, those beta cells are going to have the potential to release hormones, and those beta cells would secrete insulin. And so you would have high levels of insulin in the blood, and that will result in low blood sugar. And currently, surgical resection or taking the tumor out surgically is the only curative therapeutic option for these neuroendocrine tumors. Okay, now let's talk about diabetes. And there's a few different types of diabetes. There's diabetes mellitus that we're probably most familiar with, and that includes both type 1 and type 2 diabetes. But there's also what's called gestational diabetes. Now, what all these diabetes have in common is that it's a pathological condition that inhibits your body's ability to use sugar in the blood. So they're unable to take up sugar from the blood. And so the common thread through all of these is that it results in hyperglycemia. It results in high blood sugar levels, again, because your cells can't take glucose from the blood inside the cell. They can't respond to insulin. And with gestational diabetes that occurs during pregnancy or can occur during pregnancy, in this case, pregnant women who have never had diabetes can have high blood sugar during pregnancy because perhaps, you can have hormones that are released by the placenta that can cause this high blood sugar. And so it's just a form of diabetes that can occur during pregnancy. And it's something that goes away at the end of pregnancy. But the other two types of diabetes fall under what we call diabetes mellitus. Mellitus is a prefix that means sweet or related to honey, and that refers to the high blood sugar levels. And you can have type 1 diabetes or you can have type 2 diabetes. Let's start with type 1 diabetes. What causes type 1 diabetes? What is type 1 diabetes? Well, type 1 diabetes is an autoimmune disease, which means that the white blood cells of the body are going to attack some of our body's own cells. And what they do is they specifically attack beta cells. So here we have a drawing of the pancreas, the histology of the pancreas. Here we have the islets of Langerhans. And again, specifically what's going to happen is you have white blood cells, this little Pac-Man cell here, that's going to attack these beta cells, and it's going to destroy them. And so you're left, in type 1 diabetes, you're left with none or very few functional beta cells. So what's the consequence of that? Well, you don't have insulin production, which means that the cells are unable to take in glucose. And the result of that is hyperglycemia. And that's a problem because the cells need glucose. The cells need glucose to convert that to ATP. And symptoms can be similar between type 1 and type 2 diabetes: increased thirst, frequent urination, hunger, fatigue, and we'll talk about specifically what's causing those to happen. Now, something that's promising about type 1 diabetes, some research related to that, is what they're trying to do is they're trying to replace these pancreatic beta cells that are destroyed by the immune system and inject those into the pancreas so they can be injected into there and basically replace the destroyed beta cells. And what they're doing is they're actually coating these beta cells with some form of encapsulation to protect them from the immune system. Because if you're injecting beta cells from somebody else's body, or cells that are derived from somebody else's body, the immune system is going to recognize those as foreign and try to attack them. And so they're physically encapsulating them to protect them from the body's immune system. And this is promising research that would be very beneficial to type 1 diabetics, potentially reversing type 1 diabetes. What do you have to do if you are a type 1 diabetic? How do you have to manage it? Well, you have to regularly monitor your blood glucose, and you have to administer insulin daily because of that. And then we have type 2 diabetes. And when we talk about type 2 diabetes, we have to consider something called insulin sensitivity. Insulin sensitivity refers to your cell's ability to respond to insulin. So basically, when insulin binds to its receptor, and that's what we have going on here. Here we have insulin. Here's the receptor. When insulin binds to its receptor, that activates this signal transduction pathway, and the net effect is that glucose transporters, these GLUT4 transporters, move to the plasma membrane, and that allows glucose to move through these transporters inside the cell. That's what insulin sensitivity is, your cell's ability to respond to insulin. And you want your insulin sensitivity to be high. You want your cells to respond to insulin. When insulin binds to the receptor, you want those cells to respond, and GLUT transporters move to the plasma membrane, and glucose moves inside the cell. That's the goal. If you have early onset type 2 diabetes mellitus, or what we call prediabetes, then cells which normally take in glucose following the binding of insulin are no longer able to do so. They lose their sensitivity to insulin. And when this happens, you're in a state of what we call insulin resistance, is a term you'll hear. And that's basically an inability to use sugar in the blood. So what happens in this instance? If you have insulin resistance, then you still have insulin in the blood. The pancreas is still releasing insulin in response to high blood sugar. That insulin is still binding to the receptor. The receptor activates, but what happens is that your signal transduction pathway is messed up. And so these GLUT4 transporters are no longer able to make it to the plasma membrane, and glucose is no longer able to make it into the cell. And you might be asking, okay, well, what causes this to happen? What causes a state of insulin resistance to happen? Well, the onset of prediabetes, the onset of insulin resistance, is associated with obesity, and especially the accumulation of what we call visceral fat. So fat underneath the skin is called subcutaneous fat, and that's one thing. But this fat that accumulates in the abdomen around the viscera, around the organs, this visceral fat is different. And this visceral fat is actually more dangerous. And the reason it's different is because it's what we call lipolytically active. These lipids that are in the abdomen can break down really easy. So here we have a full triglyceride, and again, triglycerides that are in the abdomen and the visceral fat break down relatively easy. And so that results in this release of this glycerol head and the release of these free fatty acids into the blood. So the visceral fat breaks down and causes the release of this free fatty acids into the blood. The reason this is a problem is because these free fatty acids that are in the blood, they can diffuse inside the cells of the body. And when they're inside the cells of the body, they disrupt the signal transduction pathway. So that's the whole problem. That's what's causing insulin resistance. Free fatty acids from the breakdown of visceral fat moving into the cells and somehow disrupting this signal transduction pathway, so the GLUT4 transporters are no longer able to make it to the plasma membrane. And that's what causes the onset of diabetes, type 2 diabetes. So this is a really nice chart, and what this is doing is it's showing the transition from a healthy individual to someone with prediabetes to someone with full diabetes. And there's three variables that we're going to look at to determine this. One is insulin sensitivity. And like I mentioned before, you want your insulin sensitivity to be high. You want your cells to respond to insulin. Another variable that we're looking at is plasma insulin, or the amount of insulin in the blood. And here we have a nice normal level of insulin in the blood. And then the third is plasma glucose, or blood sugar levels. And here we have a nice normal level of glucose in the blood, a nice normal blood sugar level. So the question is, what causes the transition from a healthy individual to someone with prediabetes? Which one of these three variables is going to change first and cause that transition? Well, the answer is insulin resistance. And like I just showed, your insulin resistance with the state of prediabetes goes way down. Free fatty acids are getting into the cells. The cells are no longer able to respond to insulin. So as a result, your insulin resistance goes way down. And that's what causes the transition from a normal, healthy subject to one with prediabetes. Now, what variable is going to change next as a result of that? Your insulin resistance goes down. What variable is going to change as a direct result of that? Well, if your cells aren't able to respond to insulin, they're not able to take up glucose from the blood, then your plasma glucose is going to go up. And this is the hyperglycemia that we associate with prediabetes. And then what about plasma insulin? What is your pancreas going to do as a result of this? So you have high levels of blood sugar. What's your pancreas going to do? What does it show it's doing? Well, as a result of this high blood sugar, your pancreas produces large amounts of insulin, compensatory hyperinsulinemia. And the idea here is that the pancreas is really trying to release so much insulin into the blood that will allow the cells to be able to take in some glucose. And maybe it is having a little effect. Maybe the cells still are able to take in some glucose with these high levels of insulin from the pancreas. But the question is can the pancreas keep this up indefinitely? Can the pancreas continue to produce large and large amounts of insulin? And the answer to that is no. Maybe you can go months, maybe you can go years being a pre-diabetic with producing this large amount of insulin. But eventually what's going to happen is the beta cells that produce insulin are going to burn out. They're no longer going to be able to produce insulin. And so that's what causes the transition from pre-diabetes to diabetes, is that your beta cells burn out, and as a result, your levels of plasma insulin go way down. And now you're not producing any insulin at all. And so what happens to blood sugar? Your blood sugar goes up even more. And you get these super high blood sugar levels that are associated with diabetes. And all of this is presuming that you haven't made any changes, lifestyle changes, and so your insulin sensitivity is still low. And when you're in this state, when you're in a full diabetic state, this is called an insulin secretory defect, because your pancreas is no longer able to produce insulin. So it's an insulin secretory defect that represents the transition into full diabetes. So let's say you're pre-diabetic. Your insulin sensitivity is low, your blood sugar is high, and your plasma insulin levels are high. My question is this reversible? Can you go from a pre-diabetic state back to a normal healthy state? And the answer to that, fortunately, is yes. And you can do that by improving your insulin sensitivity. So you can your insulin sensitivity can go from this poor state, and it can actually be reversed back up into this high state of insulin sensitivity. And studies have shown that weight loss, and especially exercise, is a proven effective way to improve that insulin sensitivity and to go from a pre-diabetic back into a healthy state. What if you're a full diabetic? If you're a full diabetic, is that reversible? And the answer to that, unfortunately, is no. Because once those beta cells burn out, they're no longer able to repair themselves. Those beta cells have failed, and there's no going back. Now they have, like I showed with the type 1 diabetes, they may be able to inject new beta cells into the pancreas, but apart from doing something like that, the pancreas isn't able to repair itself on its own. And that's where it becomes, a serious problem. So what you have to do at that point is you have to monitor your blood sugar levels. And since you're not producing insulin, you have to inject insulin. You have to have insulin pumped inside your body. But again, even if you're injecting insulin, so your insulin levels are, at a high level, if your insulin sensitivity is low, then the cells aren't going to be able to respond. So even if you're a full diabetic, to be able to get those cells to respond, you need to improve your insulin sensitivity. And fortunately, that's something that can still be done. You can still improve your insulin sensitivity. Now, what are some of the problems with type 2 diabetes? Why is diabetes dangerous? And specifically, diabetes is characterized by hyperglycemia. So the question is, why is hyperglycemia dangerous? And the answer to that is these high blood sugar levels damage the blood vessels of the body. You have so much sugar, so much glucose rolling around in the blood vessels that it can damage the blood vessels. And it can damage the inner lining of the large blood vessels of the body, like the arteries. And that can lead to hardening of the arteries or atherosclerosis. It can lead to an aneurysm, or it can lead to a stroke. Over 1/2 of the patients with type 2 diabetes die from some cardiovascular disease related to the damage of these blood vessels here. Hyperglycemia also damages the smallest blood vessels in the body. It damages the capillaries of the body. And the capillaries are where the exchange of materials occurs between the blood and the tissues. And so if you're damaging the capillaries, then you're unable to exchange material between the blood and the tissues that it's trying to serve. And the bottom line here is if the capillaries are damaged, then the tissues they supply are going to be damaged. So for instance, what if you damage, here's the retina, which contains the photoreceptors in the back of the eye, and you can see all the blood vessels here. What happens if the capillaries that supply the retina are damaged? Well, that's going to, and you can see abnormal blood vessels here and here that are damaged by this hyperglycemia. Well, that's going to damage the retina and cause what's called diabetic retinopathy. And in fact, type 2 diabetes, because of this damage to the retina, is one of the leading causes of blindness, one of the leading causes of non-traumatic blindness. What about the capillaries that serve the neurons of the body? Well, if they're damaged, then the neurons are going to degenerate. And this can especially happen in the extremities, in the hands and in the feet. And you may have seen advertisements for this for drugs that can help. So first of all, if you have damage to the neurons that serve these areas, it's called diabetic neuropathy, and apparently this is pretty painful. It can lead to tingling and painful. It can be painful, and so now they have drugs to help reduce some of that pain. But again, at that point, you're just treating the symptoms. The cause is that hyperglycemia. And then lastly, in this example up here, if you have damage to the capillaries that supply the extremities, then if you get a cut in the toes, for instance, then because of that damage to the capillaries, white blood cells aren't able to get to the area, and you have a hard time healing. And and then you can get necrosis of the tissues. And type 2 diabetes is one of the leading causes of amputation of the limbs because the tissues are just unable to heal themselves. So what are some of the symptoms of diabetes? And some of the classic signs and symptoms that patients report are what are called the 3 polys. Poly means lots of. Okay, so you can have polyuria, polydipsia, and polyphagia. What does a polyuria mean? That means you're urinating a lot. What about polydipsia? That means you have excessive thirst. And what about polyphagia? That means you have excessive hunger. And why does this happen? How does hyperglycemia result in the polyuria, polydipsia, and polyphagia? Let's start with polyuria. How does hyperglycemia result in polyuria? Well, if you have large amounts of glucose in the blood, then you're going to have large amounts of glucose in the urine. And all of that glucose in the urine is going to take water with it, and it's going to cause you to urinate a lot. So again, high levels of sugar in the blood is going to result in high levels of sugar in the urine, and water is going to follow that sugar into the urine as a result of osmotic principles. Now, because you're urinating a lot, that means that you're going to be thirsty a lot because your body's getting rid of a lot of water, too much water. And then what about polyphagia? And this is ironic because with with diabetes, you have high levels of sugar in the blood. There's all of this nutrient. Okay, you're in a land of plenty. But because of that low insulin resistance, the cells aren't able to use it. And so you're hungry because the cells need energy. Your cells are essentially starving. And together that's called starvation in the land of plenty. There's lots of sugar in the blood, but the cells are unable to use it. The cells are actually starving, and that stimulates your hunger response. So those are 3 classic signs, and then you can do blood and urine tests to confirm the diagnosis by revealing 3 other signs. One is this hyperglycemia, but it has to be higher than a certain amount 2 different times, in this case 126 milliliters per deciliter. You can do a urinalysis, and that's going to reveal levels of sugar in the urine. Normally, you should not have any sugar in the urine. There should not be glucose in the urine, but with type 2 diabetes, there is. And then lastly, you have something called ketonuria. And this is where you have large amounts of ketone bodies in the urine. And this is characteristic of diabetes mellitus or any other type of starvation where the cells are essentially starving. So basically what's happening here is that in times of glucose scarcity, and again, you have high levels of sugar in the blood, but there's a scarcity of sugar in the cells. The cells are unable to use it. So in times of glucose scarcity or unavailability, what the liver is going to do is convert fatty acids to these molecules called ketone bodies. And these ketone bodies are secreted into the blood, and they're intended to be used as an energy source for cells. The problem is that these ketone bodies are acidic, and they can cause the blood to become acidic. And that's referred to as diabetic ketoacidosis. And that can be a serious thing. Here's a diagram explaining diabetic ketoacidosis that was published in Nature Reviews, and I'm not going to go through all of this here, but basically what happens is that, like I mentioned earlier, when glucose is unavailable to the cells, the liver is going to take these free fatty acids, convert them to ketones, and those ketones are going to go into the blood. And the next thing is that when those ketone bodies accumulate in the blood, those keto acids accumulate in the blood, it causes the blood to become acidic. And this is a state of metabolic acidosis. And as a result, the respiratory system is going to try to kick in to try to take this acidic state and move it back to neutral. And so individuals with diabetic ketoacidosis are going to have deep labored breathing. Their respiratory rate and their respiratory depth are going to go up because the respiratory system is trying to blow off high levels of CO2 to try to get the pH back to where it needs to be. And another thing that's characteristic of ketoacidosis is that the breath is often fruity because of an excess in acetone, which is a ketone body. And the last thing that I want to mention is that your race or ethnicity can affect your predisposition to type 2 diabetes. And what they're finding is that Latinos, Hispanics, or Latinos have a higher predisposition for type 2 diabetes. Black individuals have a higher predisposition for diabetes, and especially Asian Indians and also Native Hawaiians and Pacific Islanders all have a higher predisposition to acquire type 2 diabetes. And certainly some of this has to do with disparities in healthcare, access to quality healthcare, but they're also finding that there may be a genetic component to it as well, that some ethnicities may just have a higher predisposition for insulin resistance. they're more likely to accumulate visceral fat, perhaps, and they're more likely for their insulin sensitivity to be affected as a result of that. This is also true in Native communities in the United States. Type 2 diabetes is at an epidemic level among American Indians, who have the highest prevalence of diabetes of any group. And there's especially a high amount of type 2 diabetes, unfortunately, being diagnosed in Native children and young adults. And what's interesting is that there's little evidence of diabetes occurring in Native Americans prior to the first European contact. Yet today, it's pretty widespread. And so there's a multitude of factors that can contribute to this high incidence, but certainly a change from the traditional pre-reservation diet to a more Western diet, and more westernized sedentary lifestyles are certainly contributing to this problem. But again, this is something that can be addressed in all races, in all ethnicities, and it can be improved in all races, in all ethnicities.